Welcome to the Implant Supported Overdenture Attachments webinar being presented by Chris Borms, MI, COI, and we are going to begin the webinar shortly. And now it is my distinct pleasure to introduce Chris Borms, MI, COI, President of Prerecorded Corporation. Chris graduated with an accounting degree from Gonzaga University in Spokane, Washington. He attended the Dental Laboratory Technology program at the City College of San Francisco. Over the years, Chris has completed the Tyconium and the Bago partial denture programs and received his MI-COI mastership in dental technology. Mr. Borms authored the Prerecorded Corporation Technical Manual and minted 6 attachments, and he is a candidate for CDT and complete dentures. Recognized as an attachment and implantology expert, Chris has lectured nationally and internationally, and it is my pleasure to embarrass him and to introduce him this evening as our guest star. Take it away, Chris.
Thank you, Jessica. I'm glad that part's over. I'm going to get moving real quick. I'm going to skip any other further intro just because we've got a ton of content tonight. If you know me, most of the time it takes me an hour to say hello. And so we're just going to get rolling. Kind of the game plan is going to be, we'll spend about 5 minutes talking about demographics, patient presentation, opportunities to get more buy-in from your clients on overdenture therapy. We'll talk quite a bit about options. And for each different option, we'll probably spend 5 minutes on it. Most of the time talking about indications, contraindications, what type of patients would benefit from the different options. I want to make sure we leave some time for chat where you can come and say, hey, I'm having a problem on this case, or, you know, which attachment would be best for this. So with the time constraints we have, we're going to get rolling. We'll start off with disclosures. 3 disclosures. I work for the company with the blue logo. I've been there 26 years. I'm on the board of the American Denture School. And then the last one is really kind of important. And to me, that's being on the board of the NADL. And I just wanted to take a quick second and give you a quick survey of kind of what's going on with your laboratory partners. And yesterday, I spent the day at the Buffalo Prosthodontic Program. We had 16 attendees. And one of the things that I saw jaws drop when I said it was, I said, when you get out in private practice, the smartest thing you can do is partner up with the best laboratory you can. Because when you take a look at the numbers, you know, of technicians, this is a survey from 2015. You know, there were 11,250 labs going back in, 2005. Now we have 8,100 in 2015. Furthermore, you can see that 1 in 3 technicians plan to retire, most of whom are removable technicians. One of the big parts of my job is traveling all over the country. And over the last decade, I can't go into a lab of practice where I'm asked, hey, do you don't need removable technicians? So this 2015 survey was updated 5 years ago. And it got a little bit scarier because the 2 numbers that jump out are post-COVID, we're down to 5,100 laboratories. That's over half as many as there were 15 years ago. Furthermore, 1 in 3 technicians plan to retire in the next 2 years, and 2 out of 3 plan to retire by the end of the decade. So what I said to the young pros residents, again, partner up with the best lab you can, and by partner, work together on these cases, especially pick their brains. You might see 5, 10 tough cases, a month. Laboratories are seeing, 100 a month. They see a ton of the work. And if you're hearing this webinar, you're working with a great laboratory, and I commend you. So just wanted to share some of the data there. As we go forward, we take a look at different demographics. We all know 65 and older is the fastest growing segment of the US population. One of the interesting things is, 1 in 3 seniors are partially or totally edentulous. When we take a look at the totally edentulous population, 94% have complete dentures or conventional dentures or no prosthesis. So even if these numbers weren't going up, we would have 38 million potential clients because only 6% of edentulous patients have implants. A couple other really interesting numbers that jumped out at me, you're going to find I read a lot, is every day there's 10,000 baby boomers that are turning 65. Huge numbers. Furthermore, we don't need to read this whole slide, but one of the things that jumped out at me is, adults are working longer. There was a recent survey, in fact, that kind of hits home that said the average dentist was working 7 years longer than they were 15 years ago. Now, could be the stock market, could be a number of factors, but people are working longer. And when you take a look at, all the factors that come into play, people working longer, living longer, there's more seniors that need our products and services. And you take a look at the poverty rate, and that's dropped from 30% in 1966 to 9% today. So we're dealing with a generation that is the wealthiest in history. And they had parents that had plates that were flopping around if they wore them. So these are the folks that are going to live a long time. They're healthy. They want your products and services. They want overdentures. They want fixed completes, the all-on-X's. They want what you're offering to them. And, just because somebody comes into the practice and might be driving an old truck and wear shorts and flip-flops, kind of like me, they probably still have the money and they will find the money to pay for what you're offering. So I think it's a fantastic time to be offering overdenture therapy to patients. So quick client perspective, this is something I love to show. There's three things that jump out to me. We have our baby teeth, our permanent teeth. Our patients have lost all or some of their teeth. And, we could call it a third dentition. I'd almost rather call it a second chance at life because we're improving their quality of life with the prosthetics we're providing. When we talk about implant patients, Clear Choice published a few years back, their average patient who comes in the door has not seen a dentist in over 8 years. Furthermore, Dr. Resnick and Mish published a study that said their average denture wearer sees a dentist approximately almost every 15 years after receiving their denture. So that said, one of the things we're going to stress today is the importance of servicing these tissue-supported prosthetics because it'll protect our abutments, whether it's natural teeth, or implants. So talking about these, conventional denture wearers, these are the folks we really want to improve. These are the 94% of the US population who's edentulous. I mean, you can take a look at the number of stats we have here, from the surveys. Over half say it affects their love life. 3 out of 5 try and keep their dentures a secret from their partner. This kind of blew me away. And when I first presented this a few years back, I had a number of clinicians come up and say, you wouldn't believe how many overnight relines and repairs we have simply because, my wife's out of town. We got to get this done real quick. She can't see me without teeth. She doesn't know. So these are the folks that, they're not living a high quality of life. And, furthermore, 3 out of 8, it affects their career, their promotions, their earning potential, their self-confidence. So these are the people that we really want to help. And, when we talk about conventional denture patients, there's 40 million in the US. And as you kind of take a look at some of the data, what jumps out to me is there's a new denture made every 5 seconds. That's huge. And as we know, there's less and less removable technicians, there's less and less laboratories. And that's why it's really important, once again, to partner up with a really good removable lab that can help you and help the patients. So when we talk about overdentures, we're not just going to talk about implants. We can also utilize natural teeth. And there's a pro and con to each of this. And it's part of the discussion that we should have with the patients, because if the patient presents with 2 canines, in general, the patients don't want to have those teeth extracted. They've lost, the other 10, 12 teeth in the arch. They don't want to remove those. And, there's again, a pro and a con to each treatment option. We'll kind of take a minute and go through that. Right off the bat with implants, we know we don't have proprioception. The only time you have proprioception with an implant is when there's bone deformity, which is 50 times the normal bite load. So, that's when we're going to have a broken prosthesis. And, especially if we're talking about an all-on-X with a super rigid material, let's say a zirconia. if we're opposing, a zirconia full arch bridge on implants, that can be extremely destructive opposing, simply because, once again, there's no proprioception. There's no PDL. It's like driving down a potholed road in the back of a truck. I use this analogy all the time. One side of the truck has shocks, there's your PDL. The other side doesn't, that's your implant. So we have to protect our implant more than we're going to protect our natural teeth. When we take a look at, bone deformation and, the nerve receptors, it just doesn't function the same way with implants as it does with natural teeth. So when we take a look at a natural tooth, it can move, let's just say, up to 2 millimeters inside the bone because of PDL, because we have the shock absorbers. And that's under both axial loading and off-axis loading. That's a key difference between a natural tooth and an implant. So when we have an implant and we're loading down the long axis, and this can be for a single tooth, this can be for your all-on X, this can be for your, your implant overdenture. If we're loading it down the long axis, that's healthy, that stimulates the bone. The bone, we've seen cases where bone regenerates, but this stimulates the bone and maintains it. Whereas if we're off-axis loading, that's when we get those shear forces on the crestal bone, and we potentially have bone loss. Tissue follows that. Sorry, my phone started ringing. People should know not to call me. That's when we have the bone loss and breakage. Now, what would cause non-axial loading? If we're designing our single tooth and we're not keeping the forces down the long axis, off-axis loading. All on X, one of the big questions we always ask, how far can we cantilever? What's the bone quality? What's the diameter, length of the titanium implant? Because we want to know how much titanium to bone contact we have. What's opposing? What's the biotype of the gingiva? All that comes into play because we don't want to off-axis load. And when we talk like today about implant overdentures, one of the big things is going to be making sure we service the case. Because as we think about, maintaining the soft tissue support on this implant supported overdenture, we don't want to put huge torque on the implant. And if you think about the torque we're putting in on that implant, think about where you have your implant and your abutment, let's say your locator abutment in the canine, and you have a full complement, 2 posterior molars. That's a huge distance. That's a huge lever arm. And if we're not maintaining that soft tissue and bone support in the posterior, if that saddle has 0.5 millimeter to 1 millimeter to 2 millimeters of movement, that's putting a huge torque on that implant. So what happens to an implant when you put a ton of torque on it? The implant wants to bend towards that torque, and you get a bending movement. Best case scenario, you have your overdenture abutment snap or break. Worst case scenario, and this happens a lot with the thinner walled implants like the Hyosyn 3.5, the Nobel Trilo, you'll see those actually flower and break. And that's where we need to take a step back and look at it and say, it's not necessarily the implant's fault, but how did we apply that torque and the force that caused this to happen? And the key way you can do that, and one of the best things for the patient, is checking for a reline. So when we talk about attachments, there's options that are being marketed right now that say, hey, the inserts last 8 years. Well, I think if I was a clinician, I'd want my patient to come back every 12 months, because when you take a look at relines, the average mandibular overdenture, 25% need to be relined in the first year. A maxillary overdenture, 40% need to be relined within the first 3 years. So I want to check for a reline. I want to see if the patient can insert and remove it naturally. I want to make sure the inserts are still in good shape, because we know the number one cause of wear on attachments is when you get a rough surface on a smooth surface. What causes a rough surface? Well, that could be, denture cleaner. It could be a diet with lots of salad, grits, stuff like that. But, we want to maintain that soft tissue support, because big picture, we want that patient to have the confidence to wear that prosthesis, to have that quality of life, to be able to eat corn on the cob and eat vegetables and steaks and hamburgers and things like that. So how do we do that? We have the patients come in every 12 months and check for a reline. maintain that soft tissue support, maintain that firm feel of the prosthesis, because nobody wants anything moving in their mouth like this. That's not natural. So we maintain that support. We provide the patient with the service. And those are the patients that are going to be happy and say, hey, I went to Dr. Jones' practice, or, you know, my quality of life is great. I can eat again. I have confidence my teeth aren't going to fall out when I'm at church. There's a whole lot of benefits to that. Whereas that patient that doesn't come back, whether it's because we didn't tell them they needed to come back or they're not coming back, they're going to have that movement and they're going to say the exact opposite. Oh, Dr. Jones is terrible. My teeth are moving all over the place. So number one thing we can do for our patients, for our practice, and for bringing more clients in is making sure we support these tissue supported prostheses by checking for a reline. So that's my soapbox. There'll be a couple others today. So I really like the term nature's implant when it comes to natural teeth. And one is not better than the other. Natural teeth or implants. The majority of the attachments we're going to look at today, you can place on either a natural tooth or an implant. I love this quote from a recent article, May of last year. You know, to best serve our patients, we cannot default to either extreme, you know, natural teeth or implants for our overdentures. And, you know, it's not one size fits all. Now, there's a couple factors that come into play, and there's been a number of studies on endo teeth or implants. This was a recent one, 2019, talked about a 95% survival rate at a 7.5-year follow-up for both endo teeth and implants. That's fantastic. You know, we can take a look at some of the factors that favor endo. If you don't have the adequate bone for implants, absolutely keep your natural tooth. Endo, and there's a couple different ways we can try and design the restoration to protect that tooth. You know, if patients have heavy bruxism is off-axis loading every time. It shear forces on that implant. The benefit of keeping that natural tooth is we have PDL. The PDL will protect it when it's in those protrusive and damaging movements. You know, obviously pediatric patients, you know, patients that smoke, that chew, that use tobacco, things like that. So there's a lot of different patients that you're going to want to choose endodontic therapy over implants. So for example, you know, we'll use the Locator as our sample today quite a bit. You know, it's the world's most widely used stud attachment. You know, you can use a Locator on an endo tooth. And the beauty of the Locator, for example, is, you know, you've got 3 different options: a straight post, an angled, and 2 angled posts. Now, we talked about a couple different ways we can help protect our endodontically treated teeth. Yes, if you directly place one of the 3 gold options on the left, you can treat that exposed tooth structure with topical fluoride. That's going to extend the longevity of it. Cast copings have been used for years. It's an absolutely fantastic way of protecting the tooth. You know, the one key thing here is you can't necessarily go in, do endo, and press that and send it over to your lab and say, make me a cast posted coping Locator. It just won't work. Simply because if we take a look, I'm going to go back real quick. If we take a look at this cast 2 Locator, it's stainless steel. So you're not going to get a metallurgical bond when you're casting to it. Cast alloy will not bond metallurgically with stainless steel. So that little threaded post, that's only designed for mechanical retention in the casting. So what you need to help your technician do is you need to prep the canal with the spot face or countersink drill, which is the second one. And I'm going to flip here to a better slide to give them the necessary space inside the tooth to wax up around it and adequately retain the attachment. So, you know, this is where, you know, once again, I'm going to say, lean on your technician, lean on their experience, ask them for different options. You know, even though I said, you know, we're going to use Locator a lot, not every case is indicated for a Locator. So just one option there. Cast posted coping, protect the tooth, fantastic. So, you know, another study, and, you know, this was 2 studies, 2019 and 2008, it found that survival rates on endo teeth were 98%, where implants were 96%. And to me, that's probably one of the major indications of using an implant over an endo tooth. all things being equal, we have a healthy patient. There's no, parafunction habits, no tobacco use. Implants do give us a better chance of long-term success. So how do we present this to the patients where they'll accept an implant? I read a recent study that said that the overwhelming reason patients don't want implants or don't accept the treatment plan is simply because of the surgery. They are scared of implant surgery. It's invasive, and I don't blame them. I've had a root canal and a composite buildup on a lateral here since I was 9 years old, and I know someday I'm going to need an implant. I'm not looking forward to that. It's a big cost and it's a scary surgery for a lot of patients. So how can we help patients? Well, we can talk about with your conventional denture. Hey, we know you're not happy with it. One of my favorite anecdotes is I have a buddy when he provides dual arch, he charges $4,000 to $6,000 for the maxillary denture, and the mandibular denture he gives for free, simply because he knows the patient is not going to be happy with their lower denture. So 80% of conventional dentures patients are not happy, where once they get implants, 80% are happy. That's a huge swing. 80%. That's giant. So why implants? Quality of life for the patients. We can take a look at the differences between implant overdentures and conventional dentures. The aesthetics, identical. Patient satisfaction is at 100%. Improve retention. That's huge benefit of an implant overdenture. Phonetic issues, we can solve most phonetic issues with an implant overdenture simply because one of the two major complaints of patients with conventional dentures, number one is lack of retention. We know where that is. The patient's likely been a dentulous for a while. They have a flat atrophied ridge, and the flanges of the denture cannot engage that ridge to provide stability. Whereas we're going to get some stability and obviously retention with implants and attachments. And every time with that conventional denture, that tongue moves. If we don't have stability from the ridge, the denture is going to move. It's very simple that way. And again, quality of life, that chewing ability, patient satisfaction at 100% versus 39% with conventional. So, these are all great reasons why, when we're presenting implant therapy to patients, we should bring stuff like this up. But the biggest one, this was back in 2000, over 20 years ago, that 3 out of 4 patients would have chosen implants had they known about bone loss. This has got to be the number one part of your presentation, maintaining bone. Number one reason to place an implant when that edentulous patient presents. Great study done by Talgren. And when do we lose bone? And Talgren said in 25 years of observing and reports, he found that the first year of edentulism was when we lose the most amount of bone. Now, I'm not a huge fan of the mini implants. I think they absolutely have their place. I've been involved lately in a number of cases where we have 14 mini implants with fixed resin bridges. I don't think that's a good treatment, but I think with a 2, 4, 6 mini implant overdenture, it's fantastic. It maintains the bone, and maybe those can be long-term provisionals until a conventional implant can be placed. And maybe we go 2, maybe we go 4, but whatever we do, we're maintaining the bone with those. So, bone loss needs to be the number one way that we can express to the client the importance of having implants. So again, why should we, or how should we talk to patients to present implant therapy? Preserving bone, function, stability, retention, quality of life. One thing you can partner up with your laboratory on is making, study models of each. You can make that all-onyx, that screw retained. You can have a model for that. You can have a model for a bar. You can make a model that has, 2 implants on a mandibular denture, standard of care. You can show them a conventional denture model. In fact, what I would recommend doing is, I've seen this done a few times. One side of the cast has 2 implants and a couple locators, balls, O-rings, whatever it is. Patient snaps it down into place. Wow, this is great. They're going to feel a little bit of movement simply because, our implants are in the anterior, and there's going to be obviously some hinging, some pivoting as we go tissue supported. Flip the cast over. The other side of the cast is just the edentulous ridge without any implants or abutments. Seat the same denture on, they turn it upside down, it falls off. So that really shows them the difference between all of those treatment options. They can touch, they can feel, they can see the difference. It's kind of like going to a restaurant, good, better, best. Give your patients the information and the ability to help make the best decision for them. So kind of like going into a restaurant and looking at a menu, natural teeth, 100% of functional capacity. That lower denture, we only have 10% of functional capacity. Again, these are the 80% of people that are unhappy. The best return on investment for a patient in dentistry is that 2 implant tissue supported overdenture, because we take that patient from 10 to 60% of functional capacity. And again, that could be a long-term provisional where down the line, the patient gets 2, 3, a couple more implants, and we can go with something that's abutment supported versus tissue supported and take that patient from 60 to 90. But once again, that best ROI for a patient in dentistry is that 2 implant overdenture. We can take a look at tooth loss. We can restore that with conventional denture. Bone loss, again, this is one of the indicators if we were taking a look at the difference between fixed and removable. With fixed, we're only replacing the white, the missing teeth. It's a tooth-only defect. But when we take a look at somebody that has bone loss, and you can tell from that sunken look and the vertical lines, because we know that bone resorbs twice as fast horizontal as it does vertical. The beauty of removable is we can replace the bone and soft tissue as well as the white, the teeth. So, it's one of the fantastic reasons that we're going to choose removable over fixed. And in fact, one of the biggest trends we're seeing on our end is for multiple reasons. One being restoring lip contours. The patient, has the vertical lines with the all-on-X cases. We're seeing the patients go from fixed to removable. And the number one reason, in my opinion, we don't ask on every single case, but it's simply because the patients can't clean it. If they had an all-on-X place in 1985, and when they were 45 years old, what are they now? 77? That's a little 80. That's our dexterity goes down as we age. They have a hard time cleaning that. There's so many advantages to removable. I'm often asked, what would I provide my mom? To me, the Cadillac restoration, it's a bar. It's rigid or non-moving, but she can take it out at night. She can easily clean underneath the bar. As her anatomy changes, as her needs change, we can adjust the prosthesis. If she comes into the practice and says, hey, this feels loose, if it's an all-on-X or a fixed case, that's probably an hour of drilling in, removing composite, pulling Teflon tape, hoping it's just a loose screw, but we're removing the entire prosthesis and looking to see what's loose. Hopefully it's a loose screw, or hopefully a loose multi-unit. We're hoping, praying it's not anything fractured. Whereas if that same patient with something removable comes into your practice and says, this feels loose, let's say it's a locator, a couple locator studs, your assistant can remove the old locator inserts, pop in another couple, snap it in. Odds are the patient's going to be happy, they're out the door. Now, hopefully we're checking for a reline and stuff like that, but we can independently service removable. It's one of the biggest advantages. So, we take a look at what we can do with dentures versus something fixed. It's night and day. It's a dental facelift. And that's something when we take a look at what the patient's expectations is. Quick timeout. They turn the fan on. So I'm sitting here right next to the fan in the hotel, and the fan came on, so I tried to turn it off, so hopefully you can still hear me. Okay, yeah, I think I got it. There we go. First time that's happened. All right. So aesthetics, this was a great study by Gordon Christensen. Removable, any situation desired. Aesthetics, pink and white. So we're going to move on from there. So once again, 90% of functional capacity. This is the all NX. This is the rigid non-moving bar. This can be down the line. Where we want to play today is in that tissue supported, whether it's a bar or stud. We want to take that 10% up to 60%. One of the key indicators when we're taking a look at each individual patient to try and determine bar versus stud is going to be taking a look at the ridge. Now, of course, we're going to be taking a look at the vertical space we have and, what's opposing and, the biotypes and different things like that. But, a case like this where you have a patient with that tall knife edge ridge, fantastic stability. You could place a couple O-rings on this case. O-rings being the most resilient abutment protective attachment that has omniplanar movement. The patient happy because they have stability. Whereas, and this is probably what you're going to see most of the time in your practice, hopefully not, but you have a patient that presents after being a dentulous, perhaps has a conventional denture for a decade, and they've got this flat atrophied mandible, and you can put, 2 locators with a purple 8-pound inserts. I mean, 8 pounds is a tooth extractor. It's a ton of retention. But this patient is going to continue to present to your practice and say, my attachments are loose. I need to replace them. And it has nothing to do with the attachments. It simply has to do, there's no lateral. That patient, the prosthesis is always moving. Every time they function, they speak, they talk, their tongue moves, that prosthesis is moving. So you have a flat atrophied ridge, there's 2 options. You need more implants, so it's more of a removable bridge and you can maintain the stud therapy you chose, or it needs to be a bar. Number 1 indicator for a bar, patient needs stability. So, study from 2017, International Journal of Pros, surveyed thousands of patients, and the result, stability of the denture, a stronger influence on patient satisfaction than retention. So, we'll, due to some time constraints, we're only going to touch bars briefly, and this will be a course in its own. I mean, the biggest advantage of a bar is stability. Another advantage of a bar is we're splinting our weak abutments together. Now, when we take a look at the maxilla, we're taking a look at type 1 bone in the anterior, then type 2 as we go back further, and then type 3. Type 1's like oak wood, type 2's like pine wood, type 3 is like balsa wood. So if we're placing implants in type 3 bone, we can't put studs in there. There's no way that can support a stud. So how do we protect the implants to get the AP spread we need to have a full arch rigid restoration? We splint it. We tie it together to the stronger implants in the type 1 and the type 2 bone to protect the weaker ones. So we can splint and protect those. It's also easier with bars to accommodate divergent abutments. That 45-degree implant, that looks like a battleship, we can accommodate that a lot easier with bars than we can with studs. Now, there are some disadvantages. Bars are a huge ponic area to clean underneath. There's a limit to how many ponics we can put on each span. And again, the number 1 indicator of that, is going to be what's opposing. Do we have proprioception, natural dentition? Is it a force, conventional denture? Is it a huge destructive bite force, a ceramic restoration on implants? So what is the bite force? So just a couple of disadvantages there. And of course, if we're talking about that patient that presented 2 implants, flat atrophied mandible, we're going to run a bar straight across the anterior. Let's assume we have implants in the canine or lateral position. Now, why are we doing that? Simply because to get the rotation we need, to get that hinging movement we need to protect our implants as we go from abutment supported in the anterior to tissue supported in the posterior, we need to have a straight bar segment. The minute we have 2 rebar sections, we lose that rotation. So that rotation allows the patient to function without putting undue torque and stress on our implants or our natural teeth. So coming straight across the anterior, there's a strong chance it reduces tongue space. So that goes into the importance of that setup, whether it's printed, milled, or waxed, so the patient knows ahead of time that they're going to have reduced tongue space. Because the worst thing you can do is have a beautiful, let's say, hater bar done and a beautiful prosthesis, and it snaps into place, and oh, we have great support posterior. It's really feeling firm, and the patient says, I can't talk, I don't like this reduced tongue space. So that's the beauty of the provisional, making sure they can accommodate that and they're ready for it. So, in general, there's a number of studies talking about how patients prefer bars because of the, the ability to chew. I think it has more to do with stability than anything else, but in general, there's a number of studies talking about how patients prefer bars over studs. One of the drawbacks of the bar is obviously it requires a lot more space. From implant to opposing, if we're putting, for example, let's say a locator on a bar, we need about 15 millimeters of vertical. And again, this is where your provisional comes into play, is that locator housing is 5.5 millimeters wide. And ideally, we have 2 millimeters of acrylic on the buccal and the lingual. So we're talking about 15 millimeters by 9.5. Do we have the space for that? A lot of the times we think about vertical instead of that buccal lingual. And, we don't want the patients to have lips puffed out that looks like they're, somebody from Hollywood all of a sudden, because they had this huge, thickness of acrylic there. And it's one of the reasons why there's so many different attachments available, because, locators on a bar is great, especially the picture to the left. As we're going tissue supported, the locator, like an O-ring, has that omniplanar movement that allows the prosthesis to move. It allows the attachments to function without fighting or binding with each other. By comparison, if you would imagine the picture, that small picture on the left, if we had 2 hater clips up front, 2 hater clips in the back, hater clips pivot and rotate around a round section of bar. So the 2 in the front on a straight bar section, great. But if we put 2 hater clips in the posterior and we want to rotate back to tissue supported, the clips aren't designed to rotate, pivot around a bar like this. So again, we need to make sure we're choosing the right prosthetic components, the right attachments, so they function the way that the patient needs to function. We don't want to choose parts that aren't going to work the same way. So once again, if we're talking about a case and you really want to place a bar, I use the example of a hater bar. A hater bar only requires 10 millimeters of vertical from the implant to the opposing and 7 millimeters of buccal lingual thickness. So there's a lot of different options when we take a look at bars. There's 3 different types of retainers for bars. In general, the lower profile options will be where part of the retainer is built into the bar, like a hater bar, a Dover bar, a round bar. If you have the vertical space, and sometimes we have to do bone reduction to find this, we're putting an attachment on top of a bar, like a locator or a ball or an old Seiko or even a Zag. Taking that step further, there's offset attachments. And a lot of the times you're going to use these when you don't have the vertical, because instead of putting the attachment on top of the bar, you're going to be placing it on the side of the bar. And like a vertical hater bar, a vertex, a sagittal ball. And I really like the sagittal balls, because one of the beauties of the sagittal balls, either for an RPD case or a bar case, is a lot of the times we're placing the implants where the bone is. And we don't have necessarily sagittal parallelism for every case. And one of the beauties is, there was a case I was involved in the other day with a cancer patient who basically lost, all the bone in the maxilla on one side. We're coming off a central and a lateral. We're double abutting, coming off a central and lateral. And, one of the beauties of using that sagittal ball is because it allows the rotation. It doesn't require sagittal parallelism. As that patient comes off that lateral and loads that posterior saddle area, we're going to be able to rotate and allow that movement. Compare that to, let's say like, a mini Dalbo. It's going to hinge, but if it's not sagittally parallel and we need to rotate it, it's going to put undue stress on the teeth, and it's more than likely going to cause excessive wear and breakage with the attachment. So today we're just going to go through and kind of show an example of each, hater bar, straight bar sections. You need to put a clip on it. You can take it extremely low profile. You have 2 different prosthetic options. And once again, it all depends on what function you want. On the left, my left, you have a metal style clip. This gives you both vertical and rotational movement. This is what you're going to choose if this is going to be one straight bar section and you want to rotate and allow vertical movement to protect your abutments. Whereas the option on the right is the plastic clips. That just gives you rotational movement. You're going to choose this option when this is going to be fully abutment supported. We're not going tissue supported. It's all abutment supported because you get that audible snap of the plastic rider. It's comfortable to function over. And because this is once again rigid, non-moving, we're going to have a lot of retention and we're not worried about the function of the attachment. So one of the reasons I like the Hater bar, besides the fact that it's extremely low profile, it doesn't take a lot of buccal lingual space, depending upon how many abutments, the design of the case, are you cantilevering, how far are you going? You can choose this for it to be tissue supported or fully abutment supported. It gives you a lot of flexibility. Now, on the other hand, you have the attachments that are on top of a bar. These take more prosthetic space, and you can see here we have 3 locators on a bar. They give you the omniplanar movement. I think it's ideal for a tissue-supported prosthesis because that's going to allow the movement in every plane as we go tissue-supported. As you can see in this case right here, I was asked yesterday at the pros residency because one of the models we have has 2 of the drill and taps like there are in the posterior, but in the midline on the study model I have, it's got a cast 2 locator. And they said, well, why are you showing this? And I said, well, because I want to show you the pros and cons of each. And ideally for a locator bar, I want to choose the drill and tap every single time because for whatever reason, if the patient presents back to your practice and you see that the abutments are worn out, the titanium nitride is worn off and you see the silver underneath, this is a simple procedure where you take your locator core tool, and you unthread the existing attachments on the bar, thread a new one in, the patient's out the door. Whereas if the patient presents and they have cast 2 locators or laser weld locators, the only way you're salvaging this, literally chairside, is by tapping and trying to place plungers, or more than likely you're pulling the bar and that's going to your laboratory and they're going to cut off the cast 2 or the laser weld, and hopefully they're going to drill and tap and place something that you can service down the line. So a huge fan of the drill and tap simply for the ability to service and retrieve it when something goes wrong, because something will go wrong. This is also one of my favorite attachments. This is an offset attachment, comes from the lingual or the buccal. This is showing it coming from the buccal, are the plungers. And this is an absolute problem solver you want to have in your bag in the practice, because you get a patient who's got an old Bosker TMI or has an old Andrews bridge or has a beat up old gold bar that you can't get retention with anything. You can take these plungers and incorporate them into the prosthesis. If you want to have movement that's just rotational, drill a 1.5 millimeter hole in the bar, slow speed water coolant. You don't want to heat up the bar too much. And of course, the bone and tissue. You can salvage that case. Now, if you want to allow vertical movement as well as the rotational, and the reason I say rotational is if you notice the tip of the plunger is circular, the hole in the bar is circular, that's going to rotate. But if you wanted to allow vertical, you would simply make a larger hole. Or in some of these older cases, let's say an old staple, you could put it between the bar and the tissue, and this is going to allow vertical movement as well as rotational. So the plunger is a great problem solver, as well as it's a fantastic way, that it provides stability and it stops liftoff. Number one reason to use a plunger is to stop liftoff, because once that plunger is engaged, the patient can't move it. There's no movement. Now, the one contraindication for using something like a plunger would be patient dexterity, because the patient needs to be able to come in, disengage those plungers. And once again, it can be from the buccal or the lingual, whatever is easier for the patient. Disengage them a few times a day, remove the prosthesis, and of course, clean it and go forward that way. If they don't have the dexterity, do not give them a plunger. It would almost be like giving them a conical attachment like a conus Whereas if you don't remove it for a couple days, it becomes fixed. This you can still remove. It won't be fixed like a conical, but make sure the patient has the dexterity to accommodate, inserting and removing the nail heads on the plungers. So we're going to jump into studs real quick. There's two, to me, huge advantages, three actually. It's the easiest attachment service, easy hygiene, simplest prosthodontic procedures, both clinically and in the laboratory. And once again, it's the best return on investment for the patient in dentistry. Now, the disadvantages, we're not splinting our abutments together, so we're putting our implants or into good bone, or we're working with stronger teeth. We don't have stability. Biggest disadvantage of a stud is stability. We can talk about undercuts, and especially if we're talking about, a conventional denture where we have, that labial vestibule, and we're excited when we see a big one because we're like, great, we got stability, we have retention. But when we're placing an implant overdenture, we don't necessarily need to do a frenectomy on it, but we do need to block that out when it's processed. And this is where your lab's going to be a huge partner, because if that's not blocked out and the patient has to engage in undercut first and then rotate the prosthesis back, you're going to bend, fold, and break attachments. When I get calls about attachments and, they're breaking or something's wrong, if they've been in the mouth for a while, the first question I ask is, what's changed with the patient? And, I have a number of stories over the years, pregnant patients who have morning sickness, changing medication, asthma inhalers, broken arms, inserting the prosthesis with a non-dominant hand. But the second question I'll ask is it mechanical or does it look chemical? And mechanical's like where the hater clips are bending and folding. On the other hand, chemical would be like that Locator blue insert is turning clear. Once we know if it's chemical or mechanical, that way we know how to troubleshoot it. 99% of the time, if it's chemical, it's something the patient has done. If it's mechanical, it has something to do with the attachments. Either they're worn, the patient's not asserting them right. We need to realign the case. There's a number of things that way. So, yeah. So once again, we're taking that patient from 10 to 60. Here's our, our menu for the patient. And one thing to keep in mind is a question you want to ask the patient once they agree to implant therapy is, is there the potential for placing more implants down the line? Because this is going to be a big factor in where you place your implants, whether you're placing them or you're working with the oral surgeon to place them. Because, right now, if you look at this and you called me up and said, Chris, should we place them in the canine, the lateral, the bicuspid? I'm going to tell you there's only one wrong answer. And the only one wrong answer is the bicuspid, because we have an anterior and a posterior cantilever. And what we've done by placing on the bicuspids is we created a pure abutment or a teeter-totter. Solution to that, bar or place more implants. Now, if we place them in the canines, the biggest advantage of that is we have more prosthetic space, especially if we're talking about placing studs in the maxilla, because we're worried about masking those when it comes to that aesthetic zone, that smile line. The anterior maxilla facially flared, how are we going to opaque or hide those silver housings when the patient smiles? You move them to the canines, a lot of the times that's less of a concern. On the other hand, the reason you're asking about, is there the potential to place implants down the line is we want to take that patient from 60 to 90 degrees of functional capacity. And how do we do that? By placing more implants in the future and taking it from tissue supported to abutment supported. The drawback to placing the canines is if we place implants later in the bicuspids, we have a shortened dental arch because we only have the AP spread to accommodate one posterior tooth. On the other hand, and you know where I'm going with this, if we place them in the laterals, you can take a look at the difference here. We have a larger AP spread. In general, we can have two posterior teeth, and we can have something that is fully abutment supported, rigid, non-moving, whether it is fixed or removable. Now, the trade-off in the laterals is aesthetics. It's having prosthetic space for your attachments and things like that. And you can kind of see, here on this slide, the difference in AP spread with where you place your initial implants. So we'll spend a couple minutes talking about, the stud options. I just looked at the clock. I knew I was going to struggle trying to get this in an hour. I will get it. I promise I'll do it. So Locator, I'm going to say I'm going to use 75% of the time. Patient can go all over the country. People know what locators are. You can really personalize the amount of retention for the patient with 8 different retention levels. It pivots, it moves. It is the best attachment there is for a mandibular tissue supported overdenture. When we talk about space, make sure you can accommodate the amount of space it requires. And the reason I say it is the best attachment is simply because it pivots. There's nothing else out there that pivots like a locator does. And the pivoting is not the insert on the abutment, simply it's the housing over the insert. And this is really unique because with that housing staying in intimate contact, there's less wear and less chance as the patient chews, swallows, and functions. The other benefit of the insert staying fully engaged with the abutment, there's less chance of the prosthesis disengaging. So there are a lot of clones. I'll be honest, I believe we're the biggest non-OEM distributor of locator attachments. And so when the locator IP expired, I had 12 clones on my desk from all the companies that wanted to take it on. I've tested every clone and nothing pivots like a locator. Now, that being said, there is a spot for some of these rigid attachments. It's when you have 4, 5, 6 implants and it's fully abutment supported. Because if you try and use a rigid attachment like this with a rigid PEEK insert, you are going to put undue torque and stress on your implants, and you are going to wear out the abutments. It's why these, for example, are diamond nitride coated. I'm not trying to pick on any single one. I'm just saying these rigid attachments, specifically the clones, where would I use them? I would use them on a removable bridge, something that was fully abutment supported. Or if you're really fighting a case where you want to correct angulation, you can even use one of the angled abutments, like the second one on the right, and put a locator housing and insert on top of that. You're getting the best of both worlds that way. But once again, to me, the pivot is why it works. I don't necessarily want an insert that's going to last 8 years, because do I want to replace $6 inserts and check for a reline every 12 months? Or do I want to replace abutments every 5, 6 years and have the patient flopping around and unhappy and not wearing it? So I think we're doing our patient a service by bringing them in every 12 months and servicing the prosthesis. This was a really interesting study because I've always been of the mindset that in the maxilla, we place a bar because of the bone quality. This was a study in 2019, University of Pennsylvania, Dr. Anna Diatti, and it was really interesting, her success rates, because when you compare this to the other study that I referenced quite a bit, Dr. Goodacre in 1999, 1 in 5 stud cases with maxillary implants, they lost an implant. Whereas in this study, the implant success rate was 98%. Prosthesis success rate was 100%. So we can absolutely place implants in the maxilla. One of the questions we're asked all the time is, how many do I need to have an open palate? I'm going to say it depends on the ridge, because without that palate, we're losing stability. And I absolutely feel that you have to have a cast framework in there to give it more rigidity. So in general, 4 implants in the maxilla, a metal framework, you can have an open palate. So the ball abutments, these have been used for years. We're seeing a huge increase in using these in the maxilla for 3 reasons, actually. One is, some patients like to have that audible click for that security, that knowing the prosthesis is engaged. But further, anterior maxilla, sometimes you struggle, in that aesthetic zone because of that facially inclined bone and the implant's placed where the bone is, where you're struggling to mask a wider housing. Whereas with the ball abutment, the housing is 1.5 millimeters narrower. and you can rotate the housing back to the lingual to pick up even more aesthetic space. Further, we've had success with these in the maxilla because they don't have as much vertical movement. And for the patient, once they're snapped in place, it really does feel like a fixed bridge. So, you know, ball abutments, they're great in the maxilla, fantastic in the anterior maxilla, and they're great for patients who have really poor hygiene and don't clean out the inside of the receptacle style attachments, like, you know, let's say a locator, ERA, an equator, or any of the attachments like that, because you and I both know if the patient fills up that trough with calculus and debris, they're not going to raise their hand and drive over to your practice and say, I can't seat my prosthesis. No, they're going to bite it down until something breaks. If the insert bends and warps, that's an easy fix. Hopefully it's not a housing cracking or a prosthesis cracking. So that's where I'd use a ball abutment. I'd probably use that, you know, 20% of the time. Equator is kind of one of those rigid attachments. I like it on bar cases where it's fully abutment supported. It's very narrow. It's close to the same vertical height as the locator. It's a little, a tenth of a millimeter taller, but it is narrower. So, you know, you can pick up some prosthetic space that way. Looks very much like it. It has the same prosthetic techniques as a locator or, you know, an ERA or a ball. Now there's the smart box that does allow pivoting to a certain extent. So now this would be something I would consider for a tissue supported prosthesis, even though long-term, I do think locator is a better option. So, you know, smart box, I would use that on the equator probably 5% of the time for my tissue supported prosthetics. Locator RTX, it's a tenth of a millimeter wider, tenth of a millimeter taller. If you tried it when it first came out, I apologize. It was not ready for prime time yet. It came out too soon. There's some significant benefits to the RTX. The coating on the abutment, it makes the abutment last longer. When it first came out, I said, let me see over 2 to 3 years. We are seeing that. There's more pivoting with the standard locator, legacy locator, you can get up to 40 degrees. With the RTX, you can get up to 60 degrees. It's one of the reasons we don't make magnets anymore, is simply because the RTX is fantastic for patients with limited dexterity because it gets close and it self-aligns, they can bite it into place. Now, to me, the biggest improvement with the RTX is going to be your patients, whether it's a locator or another attachment, and they're wearing out the abutments. I'm going to skip to this slide and I'll come back. The RTX, the biggest improvement is that the nylon insert is longer than the housing, because I had a call yesterday where the patient with the legacy locator, there was the striations on the gold abutment. You can see the silver underneath. It wasn't all the way around it. If you see it all the way around it, it's a rough insert. It's how the patient's cleaning. But if it's just one section, what they're doing is they're biting it into place and the housing is hitting the abutment before the insert. So the beauty of the RTX is you can take that patient who's wearing out, let's say, a legacy locator, you can convert them to an RTX. It's got the better coating. The insert's going to make contact before the housing. And one of the early complaints we have with the RTX for the patient that converted were it feels like it moves a lot more than a legacy locator. So, you know, the standard inserts the RTX originally came out with were the top lines that have, the 60 degrees of movement. There's the new limited range inserts that function the same way as the standard locator inserts. They don't pivot as much. It's a plus or minus 10. This is a way you can convert those patients, give them the same feel they're used to, and you're going to have a longer quality of life for the patient, longer attachment life, longer abutment life, and less of those visits. So RTX, to me, is an absolute workhorse, fantastic option. Now, sorry, if it's okay, I'm going to go 2 minutes over. I just looked at the clock. I'm sorry. O-rings, 1 in 3 implants is a mini implant with an O-ring. Why is an O-ring used on mini implants in general? Because it's the most resilient abutment protective attachment. It pivots, it moves. Now, on the other hand, O-rings do not handle divergence very well. The picture on the right, you can see a very unique housing. It's a Saturno housing. It will pivot and accommodate for divergent mini implants. That's something you're going to want to have in your artillery for when you need that. But in general, O-rings need to be replaced every 6 months. And when a patient presents, it can be a challenge. So I'm going to advise you to get a good dial caliper. Please do not try and measure the WIS with a perio probe, a Foley gauge. Go down to Harbor Freight, pick up a $20 precision dial caliper. Because if you call me up and you say, Chris, I have a patient with O-rings, I'm not going to be real happy spending 45 minutes on the phone trying to figure it out. You're wasting your chair side time. Get the retention of the height of contour, which is the diameter of the ball, or the undercut, which is the retention zone where the O-ring sits. Either one of those measurements, we can get you the right O-ring. Because in general, from the height of contour down to the retention zone, it's a 0.4 to 0.8 millimeter drop. So if you call me up and you say, hey, Chris, I measured a 1.8 millimeter ball, I'm going to say, fantastic. Let's go with a 1.2 millimeter internal diameter O-ring. And if you say, well, it looks like there's a lot of wear, we'll go with a 1 millimeter. So that's the easiest way to service those patients. The alternative is, you can order a combo pack of 5, but O-rings can be very frustrating. There is an insertion tool designed for placing these. Traditionally, I've used a ballpoint pen and an Explorer. There is an insertion tool. You need to have KY jelly on hand because it's a brittle plastic and you're going to be turning it. And as you turn it, the O-ring is going to be compressing and then it shoots right into the housing. For many implants, it's ideal. But if you're working with some of the larger, O-ring cases, like the old Nobel 3.5 balls or a regular, 2 millimeter ball like this picture here, you can probably place them without the tool. But for many implants, it absolutely makes life easy. So that's kind of what the O-ring size chart looks like. You measure the neck, or you do the math from the height of contour. Take a look at the internal diameter. That's the size O-ring you need. So in general, with stud attachment, tissue supported, I'm going to recommend a Locator all day as long as the patient has the hygiene and dexterity. It's fantastic. Clix, I'm going to take a look at more in the maxilla, especially the anterior maxilla, or patients who have a tough time cleaning. RTX, I'm going to take a look at that if I have extremely divergent abutments, a patient with really poor dexterity, we need to help give them that guidance to seat it, or if a patient is beating up their existing attachments. Equator, this would be if you're really fighting for buccal lingual space. It's ideal for that. I like it on rigid bars quite a bit when you have the standard cap. And of course, O-rings, this is going to be, post-coping off a lateral. Or if you've got a narrow diameter implant, you want to place something like an O-ring to protect that weaker abutment. So a couple minutes over. This is my email right here, chrisappreet.com. It's real fancy. It's real hard. Feel free to email me anytime. Questions, let me know.